All right, guys. Hey, this is Scotty. We're going to do a basic overview of cardiovascular system. It's really basic, so bear with me. Uh, let's dive into it. So, cardiac emergencies are the most common medical emergencies we deal with. 600,000 deaths each year. That number keeps going up. They say figure roughly every 40 seconds someone has an acute MI. More than half of them occur outside the hospital. So, view of the heart. We get our blood from the superior and inferior vena cava. They go into the left atria. Hold on just 1 second. Sorry about that. I had an audio issue. The blood goes into the left atria, into the left ventricle, through the pulmonary vein, gets oxygenized, comes back, goes into the right atria, right ventricle, and out to our body. So valves of the heart, we have a tricuspid valve, would be the first one coming in from the deoxygenated side, the left side, goes through the pulmonary valve, comes back from the lungs into the mitral valve, and goes back through the aortic valve. So that's kind of a diagram of what I explained, how the blood flows through the heart. Atrial system. So, we assess carotid artery. We do brachial, mostly in children, but we do occasionally in adults. We got radial artery and the femoral artery. And so on the venous system, we have the external jugular vein, the inferior vena cava, the femoral vein, and the great saphenous vein, which runs along the femoral artery. So blood composition, red blood cells carries hemoglobin, gives blood its color, carries oxygen throughout the body. White blood cells, kind of like our immune system infection fighters. Platelets, what we used for coagulation. And plasma is the fluid that carries the cells. So once again, just a review of what I just said. Red blood cells give us color, carry O2 to the organs, and it carries away CO2 and waste. White blood cells, part of the immune system. Plasma carries blood cells to nutrients, and platelets are for clotting. Key pulse points. We got the carotid pulse, brachial, radial, femoral, posterior tibial, and dorsalis pedis. So assessing the pulse rate. Average adults, the pulse rate is 60 to 80 beats per minute. The normal range, 60 to 100. Average is 60 to 80. When we're assessing, is it strong or weak? We're assessing for regularity. Does it beat normally, or does it feel like it's beaten erratically or out of rhythm? So perfusion is the process of delivering blood to the organs, delivering oxygen and removing waste. The skin condition is a good indicator of perfusion. So when we're looking at these patients that are pale, diaphoretic, just look sick, how are they perfusing? So shock is a state or condition of inadequate perfusion to the organs and tissue. So they're not getting the oxygen and the blood supply that the organs and tissue needs. Signs and symptoms of shock: you could have a rapid and weak pulse, pale or cyanotic skin color. They're cool, clammy. You could have rapid and shallow breathing, restlessness or anxiety. Mental dullness or confusion, so maybe an altered mental status, nausea, vomiting, low or decreasing blood pressure. This is usually a late sign. Subnormal temperature. So, kind of what I said, low blood pressure is a late sign of shock. Cardiac compromise. Yep. So, ischemia is a condition of reduced oxygen to body tissues and cells. So, basically, when we stop getting blood supply, we start getting ischemia, and that cells start to die. Atherosclerosis, a condition in which cholesterol and cellular debris form plaque in our veins and arteries, narrowing that area and restricts blood flow. So up top's kind of what a normal artery would look like, and at the bottom you see it's kind of clogged, it's got plaque. And we run into issues when that plaque breaks away and cause a blockage. So angina is chest pain caused by reduced oxygen to the heart, inadequate blood supply. So acute myocardial infarction is a condition in which a part of the heart muscle dies as a result of no blood supply or prolonged lack of oxygen. So once that heart muscle starts to die, there's no coming back. It doesn't heal itself. It's permanently damaged. So this is kind of what happens when we get a blockage. Everything below that blockage starts to die. You've got your area of ischemia down there highlighted in red. That's where your cells and tissue starts to die. Obviously, chest pain is a symptom of acute MI. So chest pain, when we see these patients, what are we looking for? Are they sick or not sick? They pale, diaphoretic, their skin color. A condition in which the congestive heart failure is a condition in which the heart fails to pump efficiently, causing fluid to back up into the lungs. So sort of pulmonary edema. Signs and symptoms of CHF can be difficulty breathing, JVD or jugular vein distension. Their veins in their neck are bulging out. Pulmonary edema, you could have fluid in the lungs, and pedal edema is where their ankles start swelling, might have a lot of fluid retention. So, like I said, very basic. We start with our signs and symptoms. We go through our sample history, and then our OPQRST. So, when did it happen? Is there anything you do that makes it worse? How would you rate it? Does it radiate anywhere? Scale of 1 to 10, 10 being the worst pain you had in your life. How bad is it? And when did it start? Cardiac compromise. You may have a squeezing, dull pain in the chest. May radiate to the arms, neck, or jaw. Sudden onset of sweating. difficulty breathing or shortness of breath, anxiety or irritability. When you have these patients that have the feeling of impending doom, it very leery of a patient that looks at me and says they're going to die, I'm going to take that patient very seriously. Nausea and vomiting. They could have epigastric pain or abdominal discomfort, rapid irregular pulse or slow irregular pulse, sometimes an abnormal blood pressure. Sorry, guys, that went a lot faster than I thought. Still on? All right, guys, we're back. Sorry that slideshow was pretty short. We'll continue with this one. So, cardiac arrest is the cessation of cardiac mechanical activity, so the heart completely stops beating. What we said kind of earlier, 60% of it happens outside of the hospital. We need to formulate a field impression and implement a treatment plan. So the cardiovascular system obviously is composed of the heart and the blood vessels. It delivers oxygen and nutrients to the cells. I'm getting feedback. We good now? Okay. So it delivers oxygenated blood and nutrients to the cells and transports waste products to disposal sites. The heart has 4 chambers: the right atrium, the left atrium, the right ventricle, and the left ventricle. So the right atrium receives blood low on oxygen from the superior vena cava, the inferior vena cava, and the coronary sinus. The left atrium receives oxygenated blood from the lungs via the right and left pulmonary veins. The right ventricle pumps deoxygenated blood to the lungs. The left ventricle pumps oxygenated blood throughout the body. The right atrium and right ventricle are a low pressure system. It's the pulmonary circulation. The left atrium and left ventricles are a higher pressure system. It's a systemic circulation. So the myocardium is the middle layer of the heart wall. It's composed of thick muscle tissue. It's responsible for the cardiac contraction, and it's what's responsible for the ejection of blood through the heart. So the coronary arteries, the left coronary artery supplies the left ventricle and the interventricular septum. The right coronary artery supplies the right atrium, right ventricle, part of the left ventricle, portions of the conduction system. The cardiac cells have 4 properties that help the heart function: automaticity, excitability, conductivity, and contractility. The cardiac conduction system comprises 6 parts: the sinoatrial node, the SA node, the atrial ventricular node, the AV node, the bundle of His, the right and left bundle branches, and the Purkinje fibers. So, nerve stimulation of the sympathetic nerves is the accelerator. It strengthens the force of contraction and increases the heart rate. The parasympathetic nerves slow the rate of discharge of the SA node. It slows conduction through the AV node, weakens the strength of atrial contraction, cause a small reduction in the force of ventricular contraction. So the order of primary survey, normally it's A, B, C, D, which is airway, breathing, circulation, disability, and exposure. If we get a patient that's unresponsive and suspected to be in cardiac arrest, our orders change and we go circulation, airway, breathing, disability, and exposure. Acute coronary syndromes is a series of cardiac conditions caused by an abrupt reduction in blood flow through a coronary artery. So this is where we see the unstable angina, the NSTEMI, and the non-ST segment elevation MI, and the ST elevation MI. Chest pain is often the presenting symptoms of ACS. Once again, we use the OPQRST, the signs and symptoms, the sample history. Difficulty breathing can be another chief complaint. So if we have a patient that's fainted, try to determine whether she fainted from a cardiac or a non-cardiac cause. Cardiac dysrhythmia. Dysrhythmia is increased vagal tone and heart lesions. So palpitation, when the patient tells you that it feels like their heart's beating out of their chest or they have an irregular heartbeat. It's often caused by some type of dysrhythmia. So we need to inquire about when it started, how often, and how long it's been going on, and if they've ever had anything like this before. Patient may also report feelings of impending doom, nausea and vomiting. Is there trauma involvement? So hypoxia. So we want to put these patients on oxygen if they need it. But like we learned earlier today, you don't want to over-oxygenate a patient. If they're sat in the 98, 100%, they might not require oxygen. So ask about medications, prescriptions, over-the-counter, herbal supplements, recreational drugs, alcohol. So we're talking about history taking. So we need to go through does the patient have any kind of cardiac disease? Have they ever been diagnosed with any kind of valve disease or problem, aneurysm, pulmonary disease, diabetes? So the physical exam should emphasize cardiac issues. Skin color and temperature may indicate circulation problems. So we got pale, mottled, or cyanotic skin. Are they flushed, warm skin? So we begin with inspection, auscultation, and palpation. Inspect the neck and tracheal position. So we're looking for JVD, where we're looking for an inline tracheal position. So looking at the chest, is there any surgical scars? Are they on a nitro patch? Is there a pacemaker? Chest enlargement or crepitus? So we listen with a stethoscope. So assess the abdomen for distension and pulsations. So a pulsating abdomen may be a sign of an abdominal aortic aneurysm or AAA. Check for swelling. So bilateral pitting edema may be a sign of right ventricular failure. One-sided pitting edema suggests a blockage. So monitoring devices. We use a 4-lead monitor most of the time. Do a 12-lead ECG. We're looking for dysrhythmias, obviously ST elevation, depression, tachycardic, bradycardic. So pulse findings. Pulse deficit is the difference between the uh, apical and peripheral pulses. Pulseless paradoxis is excessive drop in systolic pressure. And pulseless alternance is sign and severe ventricular failure. So looking at blood pressure, elevated blood pressure, you may see anxiety or pain. Systolic blood pressure lower than 90 is hypertension or shock. Reduced stroke volume, cardiogenic shock or cardiac tamponade. So S1 occurs when the tricuspid and the mitral valves close. So S1 is the initial heartbeat that we're hearing. Decreased sound can indicate a calcified mitral valve. Obesity might play a part in it. Emphysema and cardiac tamponade. S2 occurs when the pulmonary and aortic valves close. So it's the second thump of the heartbeat. It's a louder uh, chronic. It's a louder tone. Chronic high blood pressure or pulmonary hypertension uh, decreased. You might see hypotension, and split is a right bundle branch. S3 is caused by ventricular wall vibrations. It's an abnormal sound associated with heart failure. The S4 is heard just before S1. It's a turbulent feeling of stiff ventricular hypertrophy, possible myocardial infarction. So heart murmur is an ambiguous sound from turbulent blood flow through the valves. It sounds kind of like a whistling sound. It's very abnormal. May indicate increased blood flow across a normal valve, flow across a constricted valve, or an enlarged heart chamber. You might also um, have some backflow through a compromised valve or a leaky valve. So reassessment is done on the way to the hospital. Repeat primary survey, obtain vital signs, repeat physical exam. Um, assess your interventions and create documentation. If we had a STEMI, we're going to transmit that to the hospital. So depolarization is when muscle fibers are stimulated to contract. Occurs through changes in concentration of electrolytes across cell membranes. So the cell receives stimulus from conduction. The permeability of the cell wall changes to allow sodium ions and calcium ions to enter. Depolarization spreads, causing a mechanical contraction. The repolarization begins with the closing of sodium and calcium channels. Sodium ions pumped out and potassium ions pumped in. So it's a sodium-potassium pump. The potassium channels open to allow the escape of potassium ions to help restore a negative charge to the inside of the cell. So after the potassium channels close, the sodium-potassium pump helps move sodium and potassium ions back into their respective locations, which maintains the polarity of the cell membrane. Cardiac action potential divides into 5 phases. Phase 0, the cell depolarizes and begins to contract. Phase 1, the cell begins to repolarize. Phase 2, sodium and calcium enter the cell, potassium flows out. Phase 3, this is the final phase of repolarization. And phase 4 is the resting phase. So in this diagram, you can see the QRS segment up there and what phase causes this. Refractory periods, periods in which the cell is depolarized or in the process of repolarizing. There's an absolute refractory period and a relative. So specialized conduction tissue propagates electrical impulses to the muscular tissue. The pacemaker is an area where electrical activity arises, sets rate for cardiac contraction. So the SA node is located in the right atrium. And this is the sinoatrial node. Receives blood from the right coronary artery. It's the dominant pacemaker. When we have a sinus rhythm, most of the time it's coming from this node. Impulses are spread through internodal pathways, causing contraction. The AV node. Electrical impulses move from the SA node to the AV node. Impulse conduction is delayed so the atria will empty into the ventricles. My pointer's not working on the screen. So we have the SA node up top in the right atrium, the AV node just below it. We got the Purkinje fibers right below that. So if the rate becomes rapid, not all impulses go through the AV junction. The pulses may pass into the bundle of His, right and left bundle branches, or the Purkinje fibers. So if the SA node is damaged, the farther removed from the SA node, the slower the intrinsic rate of firing is. So in the SA node, we're going to see a 60 to 100 beats per minute. In the AV junction, the pulse rate's going to be around 40 to 60. And in the Purkinje network, we're going to see, 20 to 40. The James fibers are internodal pathways. The Mahim fibers extend into the ventricles. The bundle of kit enables early depolarization of ventricular tissue. So both the sympathetic and parasympathetic divisions of the autonomic nervous system affect the heart. The sympathetic nervous system adapts to changing demands, increases the heart rate, adapts responses to increase cardiac output. The parasympathetic nervous system sends messages through the vagus nerve, which can be stimulated by pressure on the carotid sinus, straining against a closed glottis, the salva maneuver, and a distension of a hollow organ. If the brain senses the heart should slow its pace, the electrical impulse travels to the SA node, causes the release of acetylcholine. The acetylcholine signals the SA node to slow the heart. And another acetylcholine molecule travels to the AV node of the heart as a reminder. So we have our electrical impulse. It travels the vagus nerve and triggers the SA node. Acetylcholine is released. It suppresses action of the SA node, and the heart rate decreases. Baroreceptors. Um, Baroreceptors detect changes in blood pressure. So when stimulated, they generate a reflex response in either the sympathetic or the parasympathetic division. Chemoreceptors detect changes in the concentration of hydrogen ions, oxygen, and carbon dioxide in the blood. Causes of dysrhythmia. A dysrhythmia is a disturbance in the normal cardiac rhythm. You could have an acid-base imbalance. Central nervous system damage. Poisonings. You can have ventricular failure or pulmonary disease. It could be from drug effects, tricyclic antidepressant overdoses, electrolyte imbalances, hypothermia, hypoxia, heart disease, and any trauma. So we monitor these with a heart monitor. Normally, as paramedics, we would do a 12-lead EKG. A 12-lead provides information about the heart's conductive system. It records activity in 12 separate angles. It's basically an electrical snapshot of the heart, of a part of the heart. Electrode placement, we have the 4-lead there, which are limb leads. So still on electrode placement, it may be necessary to shave body hair. If the patient's sweaty, we're going to have to dry them off. We do look out for pacemakers and ports. We don't want to put our limb lead directly over that, or the cardiac patches as well, the fast patches. So the leads, there's two main groups: the limb leads, which is lead 1, 2, 3, AVR, AVL, and AVF. Precordial leads are V1 through 6. The chest leads. So limb leads, we do these 12 leads and 4 leads off Einthoven's theory. Every time the heart contracts, electrical energy is emitted. So lead 1 is attached to the right arm, right and left arms. Lead 2 runs between the right arm and right leg, and lead 3 runs between the left arm and left leg. For leads 1, 2, and 3 are bipolar leads. They contain a positive and negative pole. They measure the difference in electrical potential. The limb leads are augmented voltage AV leads that are created using the 4 limb electrodes. Leads AVR, AVL, and AVF. Combine 2 limb leads and use the other lead as the other pole. So an example, the AVR is created between the right arm and the combination of the left arm and the leg electrodes. The augmented leads are unipolar, as they contain one true pole, while the other end of the lead is referenced against a combination of other leads. An example of this would be the AVR is at the right arm referenced against a combination of the left arm and left leg. So we got the white lead is the right upper chest near the shoulder. The black is the left upper chest near the shoulder. The red is the left lower abdomen, and the green is the right lower abdomen. So we got wide on right, smoke over fire. So the precordial leads are V1 through to V6. They're unipolar and referenced against a calculated point. The Wilson central terminal. So when we have the precordial leads attached, we're looking at the heart in the horizontal plane. So leads V1 and V2 view the septum. V3 and V4 look at the anterior wall of the left ventricle. Leads V5 and V6 view the lateral wall of the left ventricle. So 12 lead placement. V1 and V2 start at the fourth intercostal space. Right. So V1 is in the right sternal border. V2 is in the left sternal border. V3 is directly in between V2 and V4. V4 starts at the fifth intercostal space in the midclavicular line. V5 is lateral to V4 to the anterior auxiliary line. And V6 is lateral to V5 at the mid-auxiliary line. Contiguous leads that view graphically similar areas of the myocardium, useful for localizing areas of ischemia, injury, or infarction. So right-sided leads used to evaluate the electrical activity on the right side. So it's going to be a right-sided 12 lead. Precordial leads are placed on the right anterior thorax. Posterior leads evaluate the left ventricle posterior wall electrical activity. 3 precordial leads placed on the left posterior thorax. So a 15 lead is a standard 12 lead plus leads V4R, V7, and V8. Allows view of right ventricle and posterior wall of left ventricle. 18 lead is standard tracing plus leads through V4R, V6R, and V7 through V9. So ECG baseline represents electrical silence in the myocardium, generally a flat, straight horizontal line. So ECG Concepts, electrical impulses moving towards a positive electrode produces a deflection above the baseline. Electrical impulses moving towards a negative electrode produces a deflection below the baseline. Graph paper moves past the stylus at 25 millimeters per second. Sure. We're going to take a quick little break.
Okay, folks, those of you that are still there, still listening on the YouTube channel, it's getting on close to 3 o'clock. So I think for today, I'm going to send you to some of the pre-recorded stuff that we had done over the last year or two. It's recent stuff, but it'll be boring. I promise you. That's just the way I roll. So go back, find this webpage that we showed you yesterday, and where most of you, a lot of you, have been to sign in. Some of you will need to sign out still here in a little while. YouTube channels, which you've been watching today. This may look a little different than some. There's tabs up here. There's CE Medical and reading assignments. Under Medical, there are some pre-recorded videos. Watch those. These are also video links. All three of those tabs. That one we actually watch. I keep thinking that's the screen, on the screen, the iPad screen. Ventilation management. If you haven't watched them, watch them. There's some quizzes. I don't have this quiz ready yet, so listen. You listening? Okay. This quiz, don't take it yet. I'm not done building it yet. It's only got 8 questions, and I'm going to add about 25 more. If I get froggy, I'll add about 50 more. Not really. I'm going to add at least 2 or 3 more about some content I know we've covered. Like yesterday, Dr. Finley. The pediatric stuff, we made some notes, made a few questions up. Yesterday, we're going to add those. These are also videos and things to do. Tap on those links. If there's something inside there to do them. If there's a place to make a comment, make a comment. This is where the class will become a little bit on you. Whoops. Those are, if you haven't seen those, that's an embolic stroke. Remember, embolic stroke will lead to an ischemic stroke. That's kind of a neat little video there you can watch. Somebody's texting me. Never mind. None of you. This is also a coronary. What was this one? I can't remember now. It's a coronary. Obviously, a coronary. There's some cardiac fat. You can tap on those things. They're a little bit interactive. You can zoom into it. Hang on, everybody. You can zoom into it and go inside. You can zoom in that. Look at that. So that's on the website. I'm showing you right now on my device. So feel free to go to your device and look it up on your own. There's a cool little video about too much calcium in the blood. Most of you don't care. All I'm getting at is look at CE Medical, tap the links, do some of the things that are skills, things that you can see that need to be done. Just don't do the quiz yet. Quiz 1 for 2020 is what it's called right there. It ain't quite ready yet. I'll send out a text message when it is ready. So just wait for that. It won't be very long, an hour or so. Let me get that done first. Whoops. Get my finger on the wrong thing. Also, at the top of the screen, reading assignments. This is where some of the homework comes in. This is, and I may need to click or check that link there on Article 1. So I will check that as well. I was told a while ago that might be an invalid link now. These are all articles that the National Registry referenced in the NCCP 16, which is the National Core Competency Program for relicensure for a national registry, which we use as basically a framework for registry and the state. These are articles that they think are necessary. So there's your evidence-based guideline for pediatric pre-hospital seizure management. And if that links to an article that's no longer valid, I'll fix it. I'll find what link in the article it's supposed to be going to now. I believe the other 5 are correct. So link to the article, read it, and then go to quiz. Quiz is not a multiple choice. Quiz is a fill in the blank. I believe it asks you to describe what you read in the article in about 50 words. Not a big deal. This is where some of your credit comes from that keeps you from having to listen to me all afternoon. You can do this on your own time. Do it yourself. This is kind of a self-driven class at this point of the day, basically. This is the last day, or basically the last couple of minutes of listening to me for the rest of this week. We'll be back online streaming like we have been today, next Wednesday, which is, help me, November 10th. Crickets in the room.
Wednesday is the 11th.
11th. Okay, that's close. Next Wednesday, the 11th, is our next day to stream. We have unless they cancel again, we have a full slate of physicians lined up to talk the next few days. Every year I've done this. This is the way it works. We have people that commit, people that back out last minute. Always leaves us kind of, what do we do? It's hard to prep for things when you don't know what you got to prep for. You know what I mean? So that's kind of where we end up at sometimes. When you don't know what you're going to prep for and you got to prep for it all, it makes it a real challenge on our end. This is where I put some of that challenge back on you. So this stuff's been here. It's relatively current, and if not, I'll fix. Do the assignments. I'll be looking at grades and submissions and stuff like that. We'll be grading some of your answers on the reading assignments. Dustin, anything to add? Scotty shaking his head no, so I think that's a no. Okay. Right. Well, from Scotty, Dustin, and myself, good day. Questions, you know how to get a hold of us. We'll see and talk to you next week. Thanks. Bye-bye.